Now, in introducing survival analysis, which what this is the name given to this general area, the key point to realize, I think, is that the data are what's called censored. We have censored data. The end point of interest has not yet happened. In a trial, it sounds very cold-blooded, but the end point of interest is actually death. I mean, we want people to live, we want the drug to work, but actually what we're interested in order to know how well it's working, is people dying. And so the end point of interest is death. And this end point of interest in many trials is not observed. When the trial finishes, some patients are still alive. And so they're what's called censored data. And that has implications for how we analyze the data. We can't use things like linear regression. We need these other models. Survival analysis is very important for economic evaluation for at least two reasons. One is survival analysis can help us identify the treatment effect, how well the treatment is working. And in many models, we are interested in what are called transition probabilities. And these are the probability over time that an individual will move to another health state. The probability, for example, a patient may get better, or in a lot of cancer cases, the probability that the patient will go from stable disease to progressed disease. And these probabilities are used particularly in things called Markov models, which we don't need to get into the technical aspect. They're used to predict the movement of patients through different health states over time. So survival analysis gives us this information. It's very important. The standard approach for taking censoring into account, this idea that when we stop collecting data, there are patients who are still alive and we don't know what happened next. The standard approach to take censoring into account is something called Kaplan-Meier estimates. If you go to a clinical journal and look at a report of a trial, almost always they'll present Kaplan-Meier curves. And almost always in clinical journals, when they report a trial, they use something called a Cox proportional hazards model in order to estimate the treatment effect. So they find things like a hazard ratio of 0.6, which means the intervention has patients dying 40% less, at a rate of 40% less than the control group. Now, these methods that are widely used in the clinical literature to report trials are not particularly helpful for economic evaluation because they describe what happened during the trial. For economic evaluation, we're interested also in what happened next. And so, because we're trying to estimate the time patients spend in different health states, this is done using things called parametric survival functions and exponential log logistic we've just had pictures of. They were both examples of parametric survival functions. Right, now, in my experience, nobody likes equations. Well, that's not quite right. You know, mathematicians like equations, a few engineers like equations, some economists like equations. Everybody else hates equations. So I'm not going to take you through step by step. The only point I want to take from this is that there's a relationship between the survival function and the hazard function. Now, if you think of a survival curve, it's showing the number of the proportion who are still alive over time. That's the survival curve. The hazard that goes with the survival curve is the instantaneous hazard at any point in time. So if a patient survives 6 months, what's the risk of them dying now? If they survive 9 months, what's the risk of them dying? That's the hazard. The survival function is showing what proportion made it to 6 months or what proportion made it to 9 months. The hazard is saying, if you survive that far, what's your risk of death in the next short time period? And so for any survival function, there's a companion hazard function. They're statistically related. That's all you need to hold in your mind. Right, so what happens is, as I highlight in the azacitidine example, different statistical distributions, different survival functions give rise to different estimates of life years, ultimately different estimates of QALYs. So there's an issue in how do we choose which survival function to use. Now, what you can do is try, and this is the recommended advice, try a wide range of functions, exponential, log logistic, Gompertz, Weibull. There's a whole series of them. And you can ask the question, how well does a particular survival function fit the data? Remember the data we've got? We've got this data from the trial, and it's showing for a limited time period what proportion of the patients were alive. And so we then are fitting to those data, we're fitting different survival functions, and you can ask which fits best. But what you often find is different functions fit equally well, because you've only got a short period of data, and a wide range of functions can fit those data points quite well. But these different functions, as we've seen with the azacitidine example, then can go off in different directions, as it were, and give quite different predictions. And so it's probably not just enough to ask, in a statistical sense, which function fits the data best. You've also got to ask a question about the plausibility of the predictions. Which function gives us plausible, believable predictions about the future? And in our example, the exponential model did give plausible explanation, essentially because everybody was being killed off. The log logistic didn't give a plausible or as plausible prediction. So it's not just the key point here is choosing a survival function is not just a statistical issue. It's also got to try and marry up to any other data we have. And for example, here, this is reporting the point at which all high-risk patients in this other trial were dead. And they were all dead by this point. And so that's external data that is supporting the idea that this might be a much more plausible model than this one, where you still have patients surviving. Okay. Right.